started. Okay, and I'll hand things over to Zach.
Hey, thank you, Patrick. I am excited to be here and speak with everyone about the connection between provider network adequacy and health equity. So before jumping into everything, health equity, it has many definitions, and there is not one agreed upon definition, but at the heart of it, health equity is all about ensuring equal health outcomes for everyone. And what we find is that policymakers in all lines of business, including Medicaid, are exploring new policies, new regulations, new laws that will require health plans to incorporate health equity considerations into their provider networks. The recording that you will see today will be focused on conversations with policymakers in the commercial market, in the exchange market, but many of the policies that they're considering have crossover to Medicaid. Many regulators in Medicaid and commercial, they look at regulations and they trade back and forth. We see that oftentimes. For example, in the video, you will hear from the director of the public option in Colorado about a new regulation that requires health plans to develop culturally responsive networks. This includes contracting with providers based off of race, ethnicity, and language considerations. On language, for example, the connection to health equity is that the research shows that individuals, when they receive healthcare in a language that they understand in their first language, that they have better health outcomes. Therefore, it makes sense from a health equity standpoint to require health plans to contract with providers that speak a language other than English. At the federal level, CMS is engaged in exploring how to incentivize state Medicaid agencies to incorporate health equity considerations into networks. In April of this year, CMS issued a request for information that focused heavily on provider networks. In that RFI, CMS asked respondents to understand how states can address cultural competency and language preferences inside network adequacy standards. Now CMS is using that information that it got from the RFI and from other areas to develop a protocol that requires states to ensure that a external quality review organization validates MCO compliance with the new network adequacy requirements. So I would expect a focus on health equity in this process. So with all that said, before jumping into the recording, Patrick, we do have a survey for folks to respond to before hitting play. So Patrick, you want to bring that up? Our first poll is, how prepared is your provider network to meet the health equity needs of your members? Are you very prepared, somewhat prepared, or do you feel not prepared at all? So you can go ahead and enter that in. Just give you a minute to respond.
Still have time for those who want to respond. Okay, last chance.
All right, well, it looks like the vast majority are somewhat prepared. So we have no respondents that are very prepared. The vast majority are somewhat prepared, and just very little are not prepared at all. So you all are in that middle, and after watching the video, we'll come back, we'll do another survey and see where we're all are at here. So with that, Patrick, I'll pass it off to you.
Okay.
Hi, everyone. I want to welcome you all to our panel focused on aligning health equity, network adequacy, and policy. I am your host, Zach Snyder. I am the Vice President of Government Affairs here at Quest Analytics. In my role, I work with federal regulators on network adequacy policy. I've been with Quest for under a year, but I have greatly enjoyed my time with the organization. Prior to Quest, I led government affairs for health carriers and have had experience working for a state-based exchange. I would like to begin our panel today by introducing our fantastic expert panelists. First, we have Kate Dzurec. Kate comes to us from our nation's capital in Washington, D.C., where she currently serves as the Assistant General Counsel for the DC Health Benefit Exchange Authority. This is the state-based exchange that serves residents of Washington, D.C. Before this role, Kate held several roles that are relevant to our discussion today. This includes, but is not limited to, being a senior advisor to Commissioner Jessica Altman at the Pennsylvania Insurance Department. She was a VP of policy at Healthsperian in Washington, D.C., where she advised national health carriers on policy and business strategy. And she was a compliance and enforcement director at CISAIO, which is the division inside CMS responsible for regulating exchange health plans. Kate holds a BA and a law degree from the University of Oregon and a Master's of Public Administration from the University of Maine. Kate, it's a pleasure to have you with us today. Next, we have Kyla Hoskins. Kyla comes to us from Denver, Colorado, one of my favorite cities, and I think one of the best state capitals in the country. Kyla serves as the Colorado Option Director at Colorado's Division of Insurance. And prior to this role, Kyla served in a variety of roles relevant to our discussion today. This includes working for Academy Health in DC, which is a nonprofit health research and policy organization. They publish health affairs. She was director of policy and research for Connect for Health Colorado. That's Colorado's state-based exchange. And she was a board member of the Colorado Consumer Health Initiative. Kyla holds a Bachelor in Science from Creighton University, a M.P.H from George Washington University, and a Master's of Educational Leadership from the Yale School of Management. Thank you, Kyla, for being here today. And finally, we have TK Keene. TK comes to us from Salem, Oregon, which is an absolutely beautiful part of the country if you've never been there. TK is the administrator for the Oregon Division of Financial Regulation, or the DFR. TK essentially serves as the Chief Deputy Insurance Commissioner for the Oregon Department of Insurance inside the DFR. Relevant to our discussion today, TK has been with this division for over 10 years, serving in high-profile legal, policy, and compliance roles. TK also leads the NAIC's PBM subgroup and is heavily involved in his division's efforts around health equity, including leading a DEI initiative inside the department recently. TK is a graduate of Lewis and Clark Law School. TK, thank you for being here today. So before we hear from our panelists, that's really where I want to focus our discussion today. These are the experts, these are the regulators. I want to set the stage and start with network adequacy. Network adequacy, as we've heard today, is important because it refers to a health plan's ability to deliver on the benefits promise. And I think we've all experienced a situation in the healthcare system where you have a healthcare need and you go to your provider directory and there just isn't the right provider, or the provider isn't close, or the provider has incorrect information in the directory. And this isn't the fault of the health plan per se. Our country has major healthcare issues that make this so, which include provider shortages and the fact that the data in the provider network is only as good as the data that the provider provides to the health plan. There's also a cost balance, where health plans are narrowing their networks to the highest quality providers to ensure quality and cost. The history of network adequacy, it goes back many years. However, the modern era really kicks off, I argue, with the Affordable Care Act. The Affordable Care Act directed health plans to ensure that networks have sufficient provider types to meet the healthcare needs of the population. Regulators at the state and federal level have created quantitative standards, which include time and distance standards, which many of you are familiar with in the audience. That's ensuring that health plans have providers that are within time and distance driving metrics to their membership. But we know that access issues persist, even with this new focus. And people are falling through the cracks. So now there is a call to incorporate providers that are essential to meeting the health equity needs of the populations that health plans serve. And that is the topic of discussion today. How regulators are thinking about incorporating health equity concerns into network adequacy. So, moving to our panelists now, Kate, I'd like to start with you. What are the challenges you have faced as a regulator on these topics?
Sure. Thanks, Zach. And I'll start with this is me talking, not my agency, all the caveats that go with that. So just want to say that up front. Because I have had the privilege to work with a lot of different people and a lot of different organizations. And many of them really wove the thread of social justice through their overall enforcement and oversight efforts. It's not just about checking an equity box once a year, right? It's an organization wide commitment to social justice. And in agreeing to this significant undertaking, we've been faced with a lot of challenges, and we still have a lot of work to do, especially when it comes to network adequacy. So, what an honor to be part of this discussion today. Um, as as a former regulator and now as assistant general counsel at the DC Exchange, I've gotten to explore how we think about networks from various perspectives. I'm fortunate that my past and current roles have allowed me to talk with different stakeholders, work with different agencies, work with different states, and see how people walk the network adequacy walk and talk the network adequacy talk. And really, where I'm coming from is that network adequacy, the term adequacy, and then the term quality, two critical terms in this space, they're not being used to their full advantage. That's what I've seen, and we need to make some changes. And so, Zach, like you were saying, a lot of people have been through this, and I just get to experience it right now. I have this new job. I have new insurance. I live in a new city. I have to find a new PCP, new dentist, new pediatrician for my kid. She's starting middle school, so I will tell you all, you better believe I'm going to have a behavioral health specialist lined up for myself. Um, but I don't have any sick time yet, right? It's not banked. I've been making phone calls to find a provider for myself, and I sit in this beautiful seat of extreme privilege. Um, and and a response I've heard more than once is, "Sorry, the doctor you're calling about is maxed out for the network you're subscribed to." Like, wait, what? And then, meanwhile, and sorry to pick on regulators a little bit, the draft payment notice for plan year 2023, the notice of payment and benefit and payment parameters, is still focusing on time and distance parameters as informed by industry standards. And then they've added wait times to network adequacy review, um, but they haven't given us a lot more around what what that means. And that's fine for, this panel where people are really thinking about, ooh, look at all the room I have to move. It's not fine for the places are like, fine, 5 minutes, 20 minutes, 15 miles. Um, there's a lot to unpack. So even after years of reliance on time and distance, we're still keeping it as a cornerstone of our network adequacy review. Um, but as a regulator, I was still hearing, I can't get a provider. I can't find a behavioral health provider. I can't find someone who understands who has cultural competence. And then on top of that, the way we are measuring and looking at the providers is problematic, right? There are providers in all kinds of networks. Dr. Jones is serving Medicaid enrollees, serving marketplace enrollees, serving employees in self funded plans. But then, when the Department of Labor, when the state regulator, when the Human Services Medicaid regulator is looking at their networks that they have jurisdiction over, they're looking at the provider list on a product by product basis. And so Dr. Jones somehow is has all of these networks, but we're stuck in this space where we just look, oh, Dr. Jones, that counts as one. But Dr. Jones also counts as one for Medicaid, and Dr. Jones counts as one for a self-funded plan. And generally, our data are terrible, and we're still saying time and distance. Let's start with time and distance. And I mentioned my seat of privilege because for people who don't look like me, talk like me, or have the resources I have, and I'm grateful for all of them, it's so much worse, right? Think about the last time you made an appointment with a provider, or, for yourself or for a loved one, right? The appointment day arrived, you got in your car, you drove the 7 miles to the appointment. It took 19 minutes. Your GPS said it would say 20 minutes, but you beat the GPS. You went in, filled out the paperwork. You had a time to collect yourself, collect your thoughts. You saw the provider. You walked out of there. Things were good. I mean, this scenario feels so good. I might use it for guided meditation next time I teach a yoga class, right? But what about for the people who got in their car and the car didn't start? What about people who have to take public transportation and the buses are running 23 minutes late and the next bus is scheduled to arrive 6 minutes before their appointment, but it takes 48 minutes to get there? What about the people who, they get 3 hours off of work for this appointment and they had to beg for that? The bus dropped them off at 8:30 a.m. Appointment was 9:15. They had the time to get settled. They had the time to think about it. They built in 45 minutes for an appointment that probably is only going to take 15 minutes. They've got an hour to get back to work. But guess what? The bus doesn't come back until 2:15 p.m. These are the nightmares that people literally live with every day. And they're not the policymakers. They're not having the conversations. We're not able to account for this. Time and distance doesn't account for the bus. It doesn't account for, if a plan is using an as the crow flies model, which in Pennsylvania that was happening. We had to put out guidance. They were saying, hey, this provider's office is only 14 miles away. Well, there was a mountain between the enrollees and the provider's office, and there was no tunnel. So it was 26 miles away, not 14, because people had to go around, right? And so we keep thinking about time and distance standards as wait times as sort of, the right place to set the foundation. And I argue that it's just not, because when we're talking about equity and social justice, the part of the social determinants of health chart that we're looking at has to be much lower than thinking about how long does it take to get there by car. And so adequate needs a new definition, right? It needs to be adequate for someone who thinks about transportation differently, thinks about when and where they can be differently. We have to rethink what is adequate, and the social justice thread needs to be woven in. Now, on top of that, we can't just weave it in so it looks like a crack across the picture, right? We have to weave that thread in so it works in the overall picture. And to do that, we really have to rethink what quality means. And quality right now sort of is limited to surveys, that were answered by people who have the time and the means to complete a survey. That can't be it. It's got to include an understanding of who's being served, what they need, and actually meaningfully asking them about what they need and what's going to be better, right? And we have to get that full picture. And so I'm super excited to be part of this discussion with Kyla and TK, because I know they definitely have been thinking about how to weave a cohesive tapestry. And I also know that they get that on this journey. We might have to take the bus. So thank you.
Yeah. Well, Kate, thank you for that. You definitely outlined a lot of food for thought here. And we will have time actually to answer some questions at the end of our discussion today. But what I want to do before turning to some questions is really turn to TK. Kate, you were a former regulator. You're now with the Health Benefit Exchange. TK, you are a regulator. You're in Oregon. Lots of big health policy issues come out of Oregon. Your offices have been looking at health equity and network adequacy. How are you looking at this topic, this connection between health equity and network adequacy when it comes to public policy?
Yeah, thank you, Zach, and thank you for inviting me to this panel. It's really great to put together this expert group of people and really appreciate the perspectives. And I'm quite sure you're not going to let me get away with just saying ditto to everything that Kate said, because that's certainly how I felt about her presentation and hearing her thoughts to these issues. So a few perspectives from Oregon, and I'd say first and foremost, one thing we've been contemplating over the last few years is the churn population as people move from Medicaid to the commercial market and back and forth, and what that user experience is like. I think we all know it's pretty rough in most instances in terms of you get a completely different product moving from the Medicaid market onto the commercial plans and then back and forth, perhaps a different group of providers and different rules of the game, so to speak. And so what could we do from a network adequacy perspective to smooth out those transitions? And I think that's really key in not only assisting consumers, but also in just getting people bought into the utility of having insurance. And so we're very fortunate in Oregon to only have about 6% of the population that's not covered, which is an extremely low number and something we're very proud of. But if people don't see the value in continuing to access insurance, whether it's through Medicaid, whether it's through commercial plans, and that number is going to slip. And so we're very mindful of that. I think the other piece I would call out is Oregon's becoming a lot more diverse, like many parts of the country. And we're hearing on a regular basis through our consumer advocacy line about people who are not finding the providers that they need in order to serve them. And they might be technically very competent providers, but they might not have the cultural competency and background to serve the population. We have a lot of agriculture workers from a wide range of different countries, and they've frequently had a difficult time finding someone who can relate to their experience in the provider community. And that's the sort of feedback we receive both to our office and to our state legislature. So those are a couple of big concerns, and what's really driven us to look at what can be done in terms of creating a cultural competency framework that we can use to assess network adequacy. To this point in time, as you outlined the history, network adequacy, at least in Oregon, has been relatively, I guess I'd say vanilla, just ensuring that there is an adequate number of providers. And so we've been thinking for 2023 and the upcoming legislative session, how can we up our game a bit in terms of what we're assessing in terms of cultural competency to be responsive to our community and our legislature. So that's something that we're contemplating in 2023, and what that would look like would be, assessing various models to determine cultural competency and how it would look in light of the created provider networks. And right now, at this point in time, I don't think we found a standard that we would be prepared to put forward. And it's certainly an ongoing conversation, but that's something that I think from a health equity standpoint, we can help drive towards and really help out with the broader conversation that's going on here. So the other issue that is frequently come up, and I'm sure we'll get to this, is really around telehealth. And so how does health equity and does network adequacy work with telehealth? And so in the last legislative session, there was a House Bill 2508 that provided some new telehealth access and set reimbursement rates for telehealth, but also prevented carriers from using telehealth to fill out and meet network adequacy requirements, because the perspective is really there is a need for in-person care. There is for certain services. There's better outcomes by having in-person care, and telehealth doesn't solve for that. But telehealth does sometimes solve for some of the gaps that we see in health equity. And so we've been trying to be thoughtful about, are there solutions through telehealth to help overcome some of our health equity challenges? And so, it's still to be determined and still requires a bit more thought, but wanted to be sure and flag that. And the final thing I'll mention before turning it over to Kyla is through the NAIC, the National Association of Insurance Commissioners, we're leaders on the Health Innovations Working Group. And so we are part of the national discussion with a whole bunch of like-minded states that are looking into this issue and really wanting to see what new parameters we can set around network adequacy, how that can be a useful tool and framework to drive some of the change that's needed and be responsive to our consumers. So thank you, and I'll end my remarks there.
Yeah, thank you, TK. All of that you're working on in Oregon sounds extremely fascinating. The legislation on telehealth in the previous session, and the fact that you're looking at new legislation in 2023 that could impact the connection between network adequacy and health equity. So this is something that I think we should all be looking at, that health plans should be thinking about, that policymakers should be thinking about. So moving to Kyla in Colorado, Colorado is making big moves. They've been in a lot of headlines with their new public option that creates standardized plans and places new requirements on health plans in order to make healthcare more affordable in the state of Colorado. So I'm really interested in this and interested in your perspective on the connection between health equity and network adequacy. So Kyla, what do you think?
Right. Well, thanks, Zach. Exciting to hear that we are making big moves. We have been lucky enough to have legislation and a governor that has really been driving this work for us here in Colorado. So just for those who might not be as familiar with what we're doing, the Colorado Option Program was signed into law by our governor last June, in June of 2021. It is a state-led public option program. And our goals are pretty clearly laid out in our legislation, which, I think can be nice sometimes. So, the goals of the Colorado option are to increase affordability of health insurance and to reduce racial health disparities, primarily through the creation of a standardized health plan that will save people money through lower premiums and lower cost sharing, and through enhanced network adequacy requirements. So the standardized plan of the Colorado option is designed to incentivize consumers to receive high value care. It is also designed to remove barriers in accessing care, where we see Coloradans of color experiencing worse health outcomes, for example, with diabetes management or maternal health. And we know that those with lower incomes, who are disproportionately people of color, report feeling the strain of high healthcare costs more than others. So by lowering costs, we believe that we can help advance health equity and remove those barriers to accessing care. And then the standardized plan is also required to have a provider network that is culturally responsive and representative of the community it serves. And again, that's direct language from our legislation. And so the vision is, if we can get people to a provider by removing the barrier of costs through the standardized plan design, then hopefully they can find a provider that is culturally responsive to their needs. That's kind of our big goal. So why do we think it's important to have a culturally responsive provider network? Well, in Colorado, we're lucky enough to have a public health institute that does a health access survey every other year. And in the Colorado Health Institute's 2021 Colorado Health Access Survey, we saw that 50% of respondents reported that they felt as if their clinician treated them with less respect, or that their clinician was providing them with lower quality of care than others. And when asked for the reasons why they thought they were being treated with less respect, the top reasons were due to their income or financial status or their ethnic background and race. Other reasons reported were due to disability status, gender identity, and sexual orientation. There's also research outside of Colorado, such as the Oakland study, that highlights the need for a diverse workforce and for a consumer to have a provider that they identify with, and how that is supportive of them getting the care that they need, and especially in a timely manner. So here in Colorado, we believe that having a culturally responsive network will improve the quality of care and health outcomes for those enrolled in a standardized plan, and hopefully it will go much further in future years for all Coloradans. But we are approaching this work in phases. So in the fall of 2021, we held meetings with stakeholders to discuss what a culturally responsive provider network might look like in year one of the Colorado option implementation. Year one for us is plan year 2023. And these meetings were extremely informative, and they highlighted a few things. I think first, they highlighted that we need data. We need data to understand what our communities look like, both our provider communities and our future standardized plan enrollees, what they look like. We also heard from stakeholders that we need to be creating requirements around provider training. Training to support providers to better understand the communities they serve and the lived experiences of their patients. We also heard a lot specifically from our disability community and consumer advocates around enhanced requirements on language access and really a specific call out on American Sign Language supports for consumers. And this will be no surprise to anybody, but we heard that we should be enhancing our provider directory requirements, not only to facilitate accuracy of the information within the provider directories, but also to give consumers more information in those directories, such as, how far is a provider office located from a bus stop, kind of to Kate's points and their remarks around, are there non-traditional provider hours? Are there weeknight, weekend hours? What languages are spoken, not only by the provider, but also by the front office staff in these offices? And then we also heard pretty loud and clear that folks really wanted more information about accessibility of provider offices. We heard a lot of personal stories about what it was like living with a disability and not knowing whether or not the place that they were going into was going to be suitable for them and their needs. And then lastly, we also heard from our stakeholders that they really wanted us to require carriers to contract with a diverse set of network providers. And, these diverse set of network providers were doulas, midwives, whether they were direct entry or certified, care coordinators, health navigators, and diabetes educators. So we took this feedback in after these stakeholder meetings last fall. And in March, the Division of Insurance adopted our first culturally responsive network regulation. And again, this is our first step in many phases, but first step in a long journey. And so what we could accomplish for plan year 2023, I'll just kind of review what we have in that regulation. First, we have requirements on carriers to collect demographic data on the providers within their network plan enrollees. The requirement for carriers to ask this information is there. However, a provider or an enrollee can voluntarily decide to provide it back. Any information that the carrier does collect here, they would be providing to the division in their network access plan, and we would be keeping that in the aggregate and confidential. Next, we also have requirements on a yearly basis for carrier customer service representatives, providers, and provider front office staff to complete an anti-bias, cultural competency, or similar training. Again, this would be every year. They would submit this data in their plan filing process. And the goal here is obviously to help doctors, providers, front office staff be a trusted, safe, and affirmative place for consumers, whether they're calling their carrier on the phone, whether they're going to the front office of their provider, or they're back in the exam room with their provider. So this is the goal of our training requirements. And then we also have some enhancements on language access supports for non-English speaking enrollees and some enhanced essential community provider standards. So in Colorado right now, we have a 30% standard, and for a standardized plan, they have to have at least 50% of those essential community providers in the service area. So those providers serving low income or underserved areas. And then we also have a requirement that carriers in the standardized plan must have certified nurse midwives. So that was where we were able to get in year one in response to stakeholder feedback to including more non-traditional providers. We felt in year one we could get to the requirement around certified nurse midwives, and we're excited to have that in there in response to our stakeholders. And then I'll just, I'm looking at the time, wrap it up with kind of where we're going. So I mentioned this is a phased approach, and we are only one piece of a larger puzzle that we're working towards here. But in year one, what we're really looking to do is collect this data through the carrier's network access plans and the other documents that we have as part of the network adequacy filing, And we really just plan to look through and analyze the data and information that's provided to see where carriers are able to meet these enhanced standards, where carriers might be falling short, and how that can inform future policy decisions. We're also starting to think about how we can tie network adequacy standards to health outcomes. So we're really starting to think about what is our evaluation plan here? How do we know that we're meeting our ultimate goal of improving quality of care and health outcomes for enrollees in the standardized plan? So that is a huge to-do, is the evaluation of these policies, and the data will help inform that. And then lastly, we're also looking at other existing structures that are out there that we might be able to leverage as a state, whether that's from other states, whether it's nationally from CMS, or whether it's through formalized structures like the NCQA's health equity accreditation. So that's also stuff that we're kind of looking at for phase 2 of this process. So I will stop there. I know that we want to leave a decent amount of time for questions. So Zach, I will pass it back off to you.
Yeah, thank you, Kyla. Very interesting information. Thank you for giving that summary of the Colorado option and just some of the, I think, really trailblazing work you're doing in Colorado to make the connection from health equity to network adequacy. And we're seeing regulators in states and at the federal level do that as well. And Colorado seems to be one of the first. So we are now moving into live Q&A. So I want to thank all of our panelists today for joining us. This was a great conversation. So thank you all for joining, and we'll see you next time.
Okay, we're back.
Very good. So Patrick, we have time for Q&A. I see a few questions coming in already. I do want to encourage the participants, please put your questions into the Q&A. But before getting into the Q&A, Patrick, why don't we do our final survey here? So if we can put that up on the screen here.
Will do.
Okay, so here we are. After watching the webinar, do you have a better idea of what health equity ideas to incorporate into your provider network? So prior to this, we asked if you feel prepared. A lot of you were in the middle, but after watching the experts have a conversation about what sort of health equity considerations they're looking at, do you have a better idea of, even absent regulations, of ideas to incorporate into your provider networks? So yes, you do, maybe, or you have no idea.
Okay, give it a couple more seconds for anyone else who wants to respond. Okay, last chance.
So the vast majority say, yes, I do. Then we have maybe, and then I have no idea, 5%. So wow, that's interesting that the respondents, they now have a better idea of what to incorporate into their network. I'm curious, what are those ideas? If anyone's willing to share those ideas that they are willing to incorporate into their network, or at least think about, have a discussion at your plan about them. And we can wait for that to come in on the Q&A as well, where you could put your thoughts in there as well. Don't have to ask a question. You can just respond to that question there. But while we wait for that to come in, let me address some of these questions, Patrick. So one of the first questions we have is adequacy to ensure access for people with disabilities. According to the National Council on Disability Health Equity Framework, lack of access to disability competent physicians and other professionals is a key contributing factor to health disparities for people with disabilities. That's a really good question, and I think that's the exact type of work that regulators are looking into right now. I think that they're looking for the provider characteristic types that are essential to meeting the health equity needs of the population. So today in networks, a health plan has to show that they have providers in their network that are there to meet the healthcare needs of the membership. And what the regulators are looking to do is look at the provider characteristic types that are there to meet the health equity needs. And one of them could be, a characteristic type could be language, a characteristic type could be access or proximity to public transit, and it could be, to your point here, competency in dealing with people with disabilities. And so that's a really interesting concept to think about moving forward as being a provider characteristic type that is essential to meeting the health equity needs of the population. Question 2 that I see coming in is, where is the line between provider network and benefit design when it comes to addressing health equity? And I think that there is a line here, because when we talk about putting into place considerations that will improve the health equity standing of the membership, a lot of this gets into benefit design. Are you providing more benefits to your membership? And here, what we're talking about is the network characteristics. So it's the characteristics of your providers. So I think when you get into proposals of, well, a health plan, you have to provide, housing vouchers, you have to provide, meals, mobile meals and things like that. I think that gets into benefit design. And really when we're talking about health equity as it relates to networks, it's all about the characteristics of your provider network. Again, going back to the last question about disabilities, do your providers have competency in dealing with individuals who have disabilities? So yeah, that's a good question. Question 3, so what is one of the biggest challenges that regulators have in setting health equity network regulations? Well, we heard a lot from the regulators in the video today, and I think one of the biggest issues is data, right? So if you as a health plan are required to contract with a certain number of providers that speak a language other than English, you need that data. You need to know which providers do speak a language other than English in order to go out and contract with them. And there's not one single source of truth on that. There are many different areas to look to, and that is a consideration that regulators think about. And I think that's a major issue when it comes to setting policy, is the data. So we have another question coming in, and Patrick, keep me honest here. I don't want to go over our time. But what parallels and trends do you see in regulations similar to those in QHP, alignment with Medicaid? So we do see a lot of sharing between qualified health plans and Medicaid. And one area where we see is the development of quantitative network adequacy standards. So at the federal level, CMS requires states to create quantitative network standards that MCOs need to comply with. And a lot of states have taken that and they've created, time and distance or just distance regulations. And at the QHP level, we see really them going in that direction. So the federal government, SSIO, they have created time and distance standards for the federal exchange. And so we're really seeing health plan regulators bring onto networks these quantitative standards that mostly come up as time and distance standards. And we heard from, Kate in the video about some of the challenges that come with time and distance. And, it's interesting to see where this will go, because, one of the issues is if you measure time and distance as just 2 dots on the map, as the crow flies, are you taking into consideration topographical features? What if you have to drive around a mountain? What if you have to drive around a lake? What if you have islands that you need to deal with? So it might look like it's only 5 miles away, but if you have to take a ferry from island to island, it's going to actually be an hour and a half. So those are things that both Medicaid plans or Medicaid regulators and QHP regulators are looking at. So we say, question number 5, have you seen regulators incorporating or leveraging telehealth? Yes, we have. At the Medicare level, at the Medicare level, Medicare Advantage, Medicare Advantage, they have a network adequacy credit that they've offered to health plans for time and distance for a variety of provider specialty types, about a dozen of them. So they say to their health plans, if you have providers in these specific specialty types, that will give you a 10% time and distance credit on the network adequacy regulations. And we're seeing other regulators look into that as well. So we're seeing CIO at the exchange level look at that, and we're seeing states also consider that about giving health plans a credit to, and the whole purpose of it is to encourage health plans to contract with more telehealth providers. That's the whole point of it. Okay, so with that, I think that's all the questions that we have for today. I want to thank everyone for your time. I would encourage you to visit our website, Quest Analytics, where we have a lot of resources for you to keep abreast of the latest regulations. If you want to connect with me or anyone else, please reach out to me, and we can have a conversation about this or any other issue. We're always happy to help and work with folks on anything related to network adequacy, because that's our passion and that's really what we are best at. So with that, I want to thank Patrick, and I'll pass it back to you, Patrick.
Thank you very much. That was a very informative presentation. Um, and what's really interesting about it is it's right in line with our annual conventions theme, which you all will be exhibiting at. So I want to invite everyone to come out to Phoenix at M.P.H 2022, September 14th to 16th. Registration's open, our agenda's done. Again, Quest Analytics is good enough to sponsor that event and will be exhibiting as well. They will be sending you an email with a link to the presentation, which I'm going to put on our YouTube page right now. If you have any questions, want to follow up with them, certainly you can do so at that point as well. You can also reach out to me if you have any questions. I can forward them on. Okay, thank you so much, Zach, Quest Analytics, and of course everyone else for your time today. Have a great day.
Thank you.